Welcome to the Pod of Inquiry, pushing the envelope for human understanding and optimization, the podcast for podiatrists. The Pod of Inquiry is designed to empower you with knowledge. What happens from there is up to you. Your host, Dr. Stephen Barrett, has designed this show to take you down some very deep rabbit holes, hopefully bringing you back out again, relatively unscathed, but cerebrally whipped, enabling a better understanding of all things worthy of inquiry. If you have more questions after the show, then that is good. The new discovery today many times was the new discovery 50 years ago, only to be suppressed or plainly ignored. Medicine and surgery can sometimes take a long while to get their paradigm shifted. We hope to have a lot of fun on this show and maybe destroy some ridiculous dogma along the journey. Thanks for joining the show today. Let's start spelunking.
Well, I'm real excited to introduce my next guest for today's episode, Dr. John Evans. Dr. Evans received his DPM from the Temple University College of Podiatric Medicine and has a BS in pharmacy from the University of Connecticut. He's also board certified by the American Board of Foot and Ankle Surgery and is chief of podiatry at Corewell Health Medical Center in Dearborn, Michigan. Dr. Evans is chair emeritus of the APMA Health Policy and Practice Committee and has served as a Medicare Carrier Advisory Committee representative for over 20 years. He is active with the American Board of Foot and Ankle Surgery, having served on multiple committees, including their board of directors for 8 years, and is the immediate past chair of their communications committee. Dr. Evans was the 2018 recipient of the APMA Award of Excellence and is the podiatric representative to the PAD Guidelines Writing Committee of the American Heart Association and the American College of Cardiology. Dr. Evans is a nationally recognized speaker on many topics, including peripheral arterial disease, diabetic foot, limb salvage, and preservation. So without any further introduction, please enjoy this conversation I had with Dr. John Evans. All right, I'm here with Dr. John Evans, and John, thanks for taking the time to come on the show, and I want to talk about peripheral arterial disease, which I know you've had a big interest in for a long time, and so why don't we just start off and you tell the audience how you got into PAD a little bit more than what they trained you in your medical training.
Well, thanks, Stephen. I appreciate the opportunity to speak with you today. As you have, we've both been practicing for a long time, taking care of legs and feet. And so we've all been involved in the peripheral arterial disease platform for a long time. Really, we know circulation has to get down to the legs and feet somehow, and it did, and then we would do our jobs taking care of that. So I've been doing this for over 35 years. And so PAD was always in the periphery of what we needed to know to make our jobs possible. So we were always looking for this. And, we take off the shoes and socks of pretty much all our patients that we're seeing every visit. So we're used to looking for signs and symptoms of problems, basically poor circulation, or wounds that won't heal, or complaints of lack of blood flow in the legs, which we would call ischemia when, the muscles start to hurt that way.
Right.
But I really started looking into it more about 25 years ago when I was doing a lot of wound care and realizing this was a major reason why wounds wouldn't heal. So looking into it more that way. And at that time, I started working with some interventionists in my area. And so started learning a little bit more about what they did. And based on that, it kind of became just an interest that I would look into. Then a number of years ago, our national association, the American Podiatric Medical Association, asked me to be a representative to the American Heart Association and American College of Cardiology. They were in the process of revising their peripheral arterial disease guidelines. And they appointed me to be part of that working group to construct the new guidelines.
Okay. And that was for APMA?
Yes.
Okay.
APMA was asked to be part of this group.
Got you.
Which was great for us because we had never been part of this this large association before, developing these guidelines. So I had the opportunity to start working with about 25 of the top vascular experts in the country on devising these guidelines. So it took a deep dive then.
Right.
And what I realized was the majority of the literature that I was researching for these guidelines was new to me.
Okay.
And I thought I had a pretty good grasp on vascular disease and such because, you know,
Right.
that's what we do.
Right.
But I realized that unless you were reading the vascular literature, a lot of the information wasn't there. Really, in the last 25 years, the whole science of how peripheral arterial disease develops has changed. And unless you were steeped in the more modern research, which certainly someone who graduated from medical school in the 80s, I wasn't, and I didn't read the vascular literature itself. I basically looked at what had came into either primary care or into the podiatric literature. There was a lot of stuff going on that I wasn't aware of. So once I started realizing that I didn't know about this, I thought, well, there's a good chance that a lot of my colleagues aren't either.
Right.
So really, we've been working on these guidelines for 3 years now. And the research around it for me started in depth about 5 or 6 years ago. I just wanted to take the information that I thought was interesting and unique and to share it with our colleagues and ideally primary care too, so we can start looking for a lot of these problems that can develop.
Right. Well, it makes a lot of sense. I mean, it's something that you're looking at every day, and if you change the mental perspective a little bit, that there's the saying, the eyes can't see what the mind doesn't know. And so we're seeing this all of the time, but once you're able to put it into a perspective that, oh, yeah, now I'm seeing this and it makes sense, that I think is going to be great. Now, are these guidelines published yet, or?
No, they are not.
Okay.
The newest guidelines were published in 2016.
Okay.
With any luck, the new guidelines will be published in the spring of 2024.
Okay.
So we're getting close, but until, we still have a few months to go before the actual new ones are there.
That'll be very interesting, and hopefully, before we wrap up later for this episode, that maybe we can give the practitioners a few little bullet points to put in their hat, so to speak, and change the way they're evaluating these people next week.
That would be very helpful.
I think it would be great. So I know you have some really good PowerPoints that we can dive into this. And so why don't you go ahead and share your screen and let's go into it.
Well, I think where we should start, Stephen, is how big a problem is peripheral arterial disease? The typical statistics you're going to hear is that it's in the United States, it involves about 8 to 10 million adults. But this was based on data that was developed in around 1985, based on diabetic information that was available then. And since then, it just keeps showing up in the literature. So that's pretty much the standard number you'll see, 8 to 10 million. More recently, evaluations have been done, and the newer numbers are probably between 21 and up to 26 million of American adults have PAD. So this is well over 200 million globally. People have this vascular insufficiency issue. So it's quite large. And of this, around 10% of them have the more severe level of this, which we would call chronic limb-threatening ischemia or critical limb ischemia. This is just a percentage of the people who have PAD, but they're the ones who are at most risk of having amputation or even dying from it, and who require treatment. The cost to the healthcare system is immense, over $21 billion a year. And you talk about polyvascular disease. Peripheral arterial disease is actually a component of atherosclerotic disease, which covers not just the legs, but also the heart and the brain. So when there are different segments of the arterial flow are involved, we call it polyvascular. And about 1 out of 5 patients who have PAD also have either coronary disease or cerebrovascular disease. And when that happens, the risks get much worse.
Hey, John, let me interrupt you there because I've heard something, and I don't know if this is true or not, but I've heard it stated that if a patient has peripheral arterial disease that is demonstrative, without a doubt, they have coronary artery disease. Is that not true?
It has a kernel of truth to it.
Okay.
Patients who have coronary artery disease, about 25% of them will have PAD. Between 20 to 35% will. Patients who have PAD have between 50% and up to even 90% who will also have coronary artery disease. Now, the problem with these things, there's an overlapping between the 3 groups. But when you look at different vascular studies that have been done, you'll find some of the more recent ones, when they're looking at PAD, only 25 to 40% of them had coronary disease also. So it's kind of hard to say exactly where the lines are drawn, but they're all arteries, and it just matters where they are in the body. And so there is some overlap between the different groups, but certainly coronary disease is the most common. It's also the one that we've developed the most efficient treatments for. So one of the things we look at is if a patient does have coronary artery disease, if they've had an MI, if they've had a stent or a bypass or something like that, you really need to be on the lookout that there's a good chance they're going to have PAD also.
Well, let me interject another question here for you, because in my clinical experience, I can't tell you how many folks I've seen that will relay in their history that they have no coronary vascular disease whatsoever, but they clearly have PAD when you evaluate them. You told me that, unless I misunderstood, between 50 to 90% of the people with PAD will also have coronary artery disease. Is that true?
Yeah, although some of the studies have shown, only 30% of them may have it. There's a definite,
but that's enough. But that's enough of a percentage. What I'm trying to do here is see if it's prudent or not. If you make a diagnosis of PAD in somebody who relates a history of no coronary vascular disease, but you diagnose PAD, aren't you under the gun a little bit that now you have to say, listen, we got to get you evaluated from a coronary vascular standpoint, because that's the stuff that people drop dead with.
You're right. It's a good point. It's arguable whether it's that it's an absolute, that it would be malpractice if you didn't. But here's something to think about. There are some new studies that have been done that look at calcium scoring of the heart.
Right.
And looking at vessel calcification in the lower legs and foot.
Right.
And there has been an association between the two, that there is a significant risk factor for people who have calcification of the legs, that they very well may have a higher calcium score of the heart. And we're finding that there'll be a few articles that'll be published within the next year or so that talk about that.
So John, let me jump in here a second. Again, I'm not trying to imply that it's malpractice at all, but it might be optimal practice that if you make a diagnosis in somebody with peripheral arterial disease and they say that they don't have coronary vascular disease, it might be prudent to get them worked up, at least by their cardiologist, or they can go next door to the imaging center and for $99 get a coronary calcium scan. It's super simple.
You're right. You're right. And I actually agree with you. I look at it when I sit down with a patient for the first time, or even when I'm just reviewing their charts with them, I go over the medications that they're on.
Mm-hmm.
And I look at that because the majority of patients, 60% of the patients in my practice are diabetic. Now, that's a high risk factor right there.
There is.
But besides that, I look at the medications they're on, and there's a good chance that they're on a diuretic, something that's going to reduce their blood pressure. They're probably on some sort of lipid-lowering therapy. And so at this point, I'm hitting some of the top risk factors for them. And if I see somebody that's just on all of these medications, but they don't necessarily have PAD, I assume they've got a high chance of having PAD unless it's ruled out. So my concern would be if you find somebody with PAD, you really need to look a little bit deeper on their medical history, because there's a good chance they're going to have some of the other risk factors that we'll talk about in just a minute or two. Right. But you're absolutely right. We should think of the different anatomic locations of the arteries as being somewhat related. They're not going to work in a vacuum. So,
right, exactly.
I agree with you. We talk about diabetes a lot, certainly in our profession, and basically 1/3 of patients with diabetes who are over 50 will have PAD. And we know that the majority of amputations that people have are done, they also have a diagnosis of diabetes. And when you put them together, someone who has diabetes and peripheral arterial disease, they have a 5 times greater risk of losing that limb and a 3 times greater risk of dying earlier than what they would have. So certainly with diabetes, the overlap and the risk of having one of these subsequent terrible activities is really high. Now, if somebody is diagnosed with PAD, the risk of these other cardiovascular events goes way up. They talk about major cardiovascular events as being a heart attack, stroke, or dying of vascular cause. And after someone's diagnosed with PAD, by year 4, they have an almost 20% chance increasing of having one of these cardiovascular events that are life-changing. And by year 2, about 6% of these patients will have a limb event, which means they've either suffered an amputation or they've had to have some sort of intervention. So when you are diagnosed with PAD, in effect, your life changes. You need to be on the scan for these other terrible things that can happen, not just in the legs, but either a heart attack or a stroke.
Mm-hmm.
PAD tends to get worse the longer you have it. Now, we don't think about people who have peripheral arterial disease until they actually present with symptoms. But the atherosclerotic process actually begins when they're teenagers and gradually worsens. The problem is we don't diagnose it until they become symptomatic. Right. It would be nice to know if you're on that pathway before you get to the point that you're symptomatic. And yet, the majority of patients who have PAD are asymptomatic. But 5 years later, they're going to likely have claudication, 1/5 of them will, or 15% will have had some sort of more severe condition or even dying. And the claudication symptoms also develop after 5 years. The risk of that goes way up. The critical limb ischemia or chronic limb threatening ischemia, people who have that severity of PAD, at 1 year, 30% will have had an amputation, and a quarter of them will have died.
Jeez.
And there's a category we'll talk about in a few minutes that's acute limb ischemia. And this is an emergent event where all of a sudden your arteries have been clogged up. And really at 1 month, a third of these patients will have had to have undergone an amputation, and a quarter of them are dead.
Wow.
So it's a progressive disease that it doesn't have to follow the asymptomatic to claudication and gradually worsening stage. Sometimes we just aren't aware of how bad it is until there is one of these acute limb ischemic events. But one of the problems we see with PAD is that the majority of patients have no symptoms, or they have symptoms, but they're attributed to, oh, you've got arthritis, or, oh, you're just getting old.
Right.
But only a small fraction of the patients who have PAD have the typical symptoms of ischemia. This would be, they would come in and they'd have claudication symptoms, which is the muscle pain that's caused by poor arterial flow that's aggravated by activity or exercise. The ones who walk and then after a block, they have to stop because their calves or their thighs or buttocks are hurting. And they rest and then it goes away. Kind of a little bit like you would see in the heart if we're talking about that.
Right.
But really only less than 15% of patients have those typical symptoms. So if you wait until someone is symptomatic, meaning they either have claudication or they have wounds that won't heal on their legs or feet, if you wait for that, you're going to miss up to 90% of the people who have PAD. So again, this is something it would be nice to know before it got to that level. And yet, unless you're really, really looking for it, it's likely to be missed. So in your history, Stephen, have you ever been surprised by patients who ended up having PAD and it's like, you missed it? Because I know I have.
Well, I think that, our discussion of PAD here indicates how the slide that you just showed, if you wait for, that they demonstrate intermittent claudication, and that's your definition of PAD, of course, there's a lot that's flying underneath the radar. And even if you're, kind of up on a lot of this stuff, you only think of smoking, diabetes primarily, and then if they've had some cardiovascular event antecedent to them presenting to you. But no, I think your point is that a higher degree of understanding what we're talking about today is going to lead to a higher degree of diagnosis, because so much of this is asymptomatic.
Yeah, I totally agree. And unfortunately, there's a lot of risk factors that are involved with PAD. And here is one schematic illustration of them that really, probably the top risk factor that we see is age. Because every decade, your risk goes up. So as long as you're living, it's going to gradually get worse along those lines. But the highest risk factors that we see are people who are smokers or have a history of diabetes. Mm-hmm. And more recently, we are seeing that renal insufficiency is also high on this list, along with hypertension or these lipid disorders that we would consider dyslipidemia, which is basically, for most people, it would be your LDL is high. So these are things to look at. And one of the things that I think about when I see a patient is I'm looking through their medical history. And they may not be aware of the fact that they have dyslipidemia or renal insufficiency. But if I look at their medications, it gives me an idea of what doctors are treating them for. And it's kind of up to us to put the pieces together and saying, you've got a lot of risk factors here. But, of all of them, smoking is probably the one that they have the greatest control over.
Mm-hmm.
And I'm sure you've seen this with your patients. Smoking is so difficult to get that addiction under control.
Right.
And yet it causes so many repercussions down the road.
Right. No, I totally agree. It's a very powerful addiction and not so easy to treat. Now, looking at this graph, John, these risk factors have to be cumulative as well, right? So if I'm a male and I'm diabetic and I smoke and I have high blood pressure and my lipids are askew, and probably if I have all of those, my homocysteine is going to be high. You can see where this is all going.
You're right. They are interrelated. And this graph really doesn't separate how it would be when you do get the additive and cumulative effect of a number of these pathologies together. So, yeah, these are the things to watch for. And something I really wasn't that aware of is that the public awareness of peripheral arterial disease is quite low.
Mm-hmm.
A minority of U.S. population people are aware that PAD is pretty dangerous. Most of them think it's just, it's not that bad. We know that cancer, heart disease, we understand that these are major life-threatening conditions to understand. But peripheral arterial disease doesn't make the list. And even when you look at primary care physicians, studies have been done that show that a lot of them are unaware of whether their patients have a PAD diagnosis. A major study was showing that less than half of the physicians were aware. And as you can imagine, if your primary care team isn't aware of the diagnosis, then they're not going to be treating appropriately with all the guidelines-directed medical therapy that they could to help stem, the development and worsening of this problem.
So what you're saying here, John, to be clear, is that even physicians who are aware of PAD only diagnose it 50% of the time?
Well, what this study looked at primary care physicians around 2000.
Okay.
It was a major trial called the Partners Trial. And when they were looking at this and they were interviewing and going through talking to patients and their primary care physicians, PAD was not showing up as one of their diagnoses of patients who had it less than half the time. So it's one of these things that I can't really hang my hat on it as that's how it is, but it pretty much implies the fact that PAD is not within the top 10 things physicians are looking for unless you're going to a specific physician for that problem.
Right. Okay.
And yet it probably should be for the mortality and morbidity of the problem.
Right. And I'm going to ask you at the end here about early testing, early diagnosis, because this is a pretty big segment of the population to just ignore until they have a symptom.
Oh, you're right. Absolutely. But just to talk a little bit about the different types of arterial disease. The arteries come in different sizes. I mean, you've got the aorta, which is huge, and then you've got the capillary bed, where you've got these microvascular vessels where the actual oxygen transfer into the tissue occurs. And so most of when we're talking about PAD, we're talking about the macrovascular component. These are the arteries, the ones that we can either visualize or use when we're taking blood pressure and such like this. And the majority of our treatments, certainly our interventions, which are many, and they're amazing, how we can actually go in and clean out arteries or do bypasses and such like this. They have to do with the larger arteries, the macrovascular. So we're talking about typical atherosclerotic changes, or if somebody throws an emboli, or they have inflammation of these large vessels due to different inflammatory situations, or the blockage of these little blood vessels that we call thrombogitis obliterans, this TAO type thing that we see, that we talk about, okay, these are vascular events. But what we don't talk about are the changes that go on in the microvascular vessels. And actually, this is where PAD develops from this microscopic, this cellular level, where the endothelium cells that line the vessels stop working well, or there's arterial remodeling that occurs that isn't helpful to the vessels, these type of things. Now, we don't talk about microvascular changes much because until recently, we really couldn't measure them.
Mm-hmm.
And we really didn't know how to treat it. But that is changing, as we'll see, down the line. But the macrovascular disease is often overlooked. These are the tiny vessels, the 100 micrometers in diameter. I mean, these are like 10 times smaller than even the small vessels that we talk about, that we look at. But 1 out of 6 people who have an amputation have microvascular disease without the macrovascular component. And this is not necessarily a direct component of atherosclerosis, but it is part of the early development, how it occurs. And we see it when we're talking about these major disease problems of peripheral neuropathy, or retinopathy in the eye and nephropathy in the kidneys, which are major health concerns that physicians deal with. And this, Stephen, you're one of the national experts in neuropathy. You know how difficult and how life-changing these conditions can be.
Yeah, absolutely, John. And this slide brings to mind a couple of things that I wanted to drill down on a little bit more, because the average person that's evaluating PAD is taking their dorsalis pedis and posterior tibial pulse. It's like, all right, great. Got pulses, I feel it, all's good, but then you've got skin that is xerotic, thin, loss of hair growth, all of this other stuff. Just because you palpate the pulses doesn't mean they don't have this microvascular disease. And now a message from our sponsor. Well, folks, if you're over 40 and you're not using a supplement to augment nitric oxide production, you should really rethink that. This molecule is absolutely imperative to health, not to mention the cardioprotection. Nitric oxide is a physiological molecule that does so many things for your health. I never miss a day of nitric oxide supplementation. That's how important it is. Long overdue, there is now a nitric oxide replenishment formula without the fear of oxalates. Approved Medical Solutions does not use beets, spinach, or arginine. Approved Medical Solutions is proud to offer our audience their oxalate-free nitric oxide formula. If you are not a healthcare provider, you can still get started by going to approvedmedicalsolutions.com and use the code SBarrett at checkout, and you will receive a 10% medical discount savings. For licensed practitioners, just go to approvedmedicalsolutions.com and register. They have unique bundles for all of the full-fledged spelunkers of the Pod of Inquiry. Use Pod of Inquiry at checkout after registration, and I am certain you will be pleased not only for yourself, but for all of your patients. Here's a little secret. If you order their testing strips and test every patient for a few clinic days, you will see that nearly every one of them will be deficient. When they see this result, they will want you to start them on it immediately. Now, thanks to Approved Medical Solutions, you can give them the best care without the worry of oxalates. Thanks for watching. You can start today.
You're right. You're right. And up to recently, we really didn't have ways of looking at the microvascular component. Fortunately, now we actually do. There's a few products on the market that look at the actual tissue oxygenation of the dermis, which is where we tend to see the actual transfer of oxygen from the arterioles to the venules and then into the tissue that occur. And so they're out there now. It's just that people really aren't using them that much unless they're doing research, or they may have a specialized wound clinic, or they're using them more in dialysis centers now to basically look for these concerns. But at least we have ways now of looking at measuring how this can occur. And because of that, we're going to be able to develop new treatments that work at the root development of atherosclerosis.
So, John, let me ask you a couple of questions. I'm assuming that you're talking about maybe SPY technology, where they're using some type of an indocyan green, or what about that? What about thermography, TCPO2? What about those diagnostic modalities?
No, they're useful. They are.
Okay.
The problem with them has been, other than SCAI, with thermography and looking at TCPO2 levels, a lot of them are either difficult to reproduce, or as far as the partial pressure, it tends to be evaluator bias. So you couldn't necessarily reproduce their vessels like that. But there's a couple of newer technologies out that involve near-infrared spectroscopy, or spatial frequency domain imaging, which are both devices that measure the oxygenation of the dermis. They look at hemoglobin levels that are either oxygenated or deoxygenated, and they can actually determine the levels between the superficial and deep dermis just by taking a 3-second scan, non-contact, holding a device, about, a foot or so from the extremity, in our case, the foot, and just taking a snapshot. So there's a couple of devices out. One is called Snapshot by Kent, is the company that does it. And the other is Clarify, that's for the company Modulum. So these give incredible information on this level, and more research is coming out talking about it. And certainly within our profession and within the wound care, the spectrum, we're seeing these technologies utilized to help determine, because face it, if somebody's got a great superficial femoral artery or a great posterior tibial pulse, it really doesn't matter if the oxygen can't get to the tissue. So this is one way of being able to look at that and to utilize that. So at least we have a couple of clinical aids that are on the market now that we can utilize, and we'll be seeing them become more and more available to clinicians.
Is there any merit in thermography, because that's relatively inexpensive?
Oh, it's tremendous. But thermography, because it's not really specifically related to oxygenation. It's at least what my own perception of the great benefit has been in developing areas of at risk for ulceration, or to determine if there is a major difference in perfusion between one side or the other, just depending on warmth. So it's not just circulation, but you're also basically your expertise in the neurological component of the autonomic system and regulation of vasodilation and such. What are your thoughts on that?
Well, my thoughts are that thermography is pretty valuable because it's objective. It takes out anybody saying, well, it's a placebo effect, or, like people are using a visual analog scale for pain. Well, those are super subjective. But if somebody says my foot's really cold all of the time, and you have thermography that shows the foot's really cold all the time, then, it's pretty hard to argue with that. But it's more of at least in my mind right now, it's more of an academic interest because it's not widespread in the average practice. Maybe it will be once they get more parameters, but I see David Armstrong talking a lot about thermography and its value. And I think there's definite value there. It's just, how do you position it? How do you quantify it? How do you actually take it? I mean, what's the temperature of your room one day versus another day? I mean, there's a lot of variables that you have to take into consideration, but I still think it has some merit for future investigation and implementation, because it is very inexpensive. I mean, you can get a pretty darn good thermography camera for, a couple $1,000s that pretty darn accurate. So I think there's a future in it, but maybe not just yet.
No, I totally agree. And in fact, a lot of the remote therapeutic options, one area they've been looking at has been the utilization of thermography on a home use, because it is objective, right, and it's quantifiable. And as long as you've got a way of being able to put things into perspective, as you mentioned, with room temperature and with different environments and such, it's very useful.
Right. Right. Well, I would love to talk a little bit about because you've touched on the microvascular disease. I think this plays a lot in the peripheral neuropathy that we deal with frequently. And a lot of the peripheral neuropathies that are categorized as idiopathic really aren't. I think, you just have to keep turning over the rocks and you find that there is a cause. But regardless, I don't know of any peripheral neuropathic condition that doesn't have some element of neuroinflammation and some element of microvascular impairment at let's call it the vascular neural interface. And so if you break down peripheral neuropathies into compressive versus non-compressive, and people will say, well, what the hell is that? And the answer is, well, there are certain neuropathies like diabetic peripheral neuropathy that a lot of the symptoms are caused by the edematous nature of the nerve getting, the nerve gets fat and swollen in a tight tunnel. And so you have this focal compression. Well, where you have any focal compressions, you're going to have a decrease in circulation. So you're adding this negative synergistic effect of, okay, I've got maybe microvasculature that is impaired, and now I'm putting more pressure on the microvasculature. And these are lumens. They're tubes. And if the tube is compressed and it also has disease, then it's kind of intuitive that that's going to be more of a problem than somebody that didn't have a tube that was diseased and maybe only partially compressed. So I think there's a lot of interplay here. And I don't think that if you really ultimately want to treat patients the best with neuropathic conditions, you have to pay attention to the vascular component. And I think you could say the other way around. People with PAD, we should really be looking at the neuropathic or the neurogenic aspect of what's going on with them, because they may indeed have both things against them.
I totally agree. We're seeing it a lot even in dementia research, of vascular dementia as being a major component of what we may be calling aspects of Alzheimer's, or even the development of Alzheimer's. Very well, a number of researchers are saying, look, there's a significant vascular component to that affecting the nerves.
Right.
So you're right. I think it's hard to separate the two because they're so intertwined. You can't have one without the other.
Totally agree. So let's go into this slide about the combinations of the PAD and the microvascular, or microvascular versus the macrovascular.
Yeah, this just talks about the fact that they work together and are synergistic in a way that with microvascular disease, if they have that alone, just this microvascular ischemia, they have a 7 times greater risk of having an amputation. If they have strictly macrovascular disease, they have a 20 times greater risk of having an amputation. But if they combine the two, which is what, face it, most people have, is a combination of both, it's up to 60 times greater risk of losing a limb. So there's a synergistic relationship between these two. And so even though we really only have ways of measuring the macrovascular, the larger vessels at this point, we need to take into consideration that, if we don't do something about the micro cause, we're not going to get as good as a result when it comes to treatment. So there's a lot of new research that's going into genetics and working on cellular modifications to deal with microvascular. It's pretty much now it's all academic, but it's all pretty exciting, and we'll be seeing more and more of it. But at the end stage of peripheral arterial disease, the more serious aspect that will develop is something that we call critical limb ischemia, CLI, or more modern term would be chronic limb-threatening ischemia, CLTI. You'll see these terms used, and they're basically interchangeable, but they're more or less leaning towards CLTI as being what we're talking about here.
Okay.
And these are patients that will have chronic ischemic rest pain that have been going on for over 2 weeks. So this isn't just ischemia or claudication symptoms on exertion. This is without exertion. They're just hurting because this tissue doesn't get enough oxygen and the nerves are screaming.
Right.
Or patients have developed ulcers that won't heal in the legs or the feet, or they have developed some degree of gangrene. So this CLTI talks about somebody that falls into this more serious component. And it's kind of like the end stage of the chronic development of disease. And about 2% of PAD patients will have this at any time, but if you have PAD, about 11% of patients will progress to this more severe level. And unfortunately, this is usually when treatment begins. This is when you see people being referred for interventions or something along those lines.
Right.
Now, CLTI is not good to have. People who have it after 4 years, between 1/3 and 2/3 of these patients will have had an amputation of a leg. And at 1 year, 25% of them will have died, and over 60% will have passed by 5 years. So this is a very dangerous disease to have. And yet, when we look at the mortality rates compared with those of your more common cancers, really it's more dangerous than all of them except lung cancer and possibly pancreatic cancer. But, knowledge of this really isn't that well known. But we should be thinking about, what's going to kill people. CLTI is up near the top, and yet
nobody's talking about it.
Yeah.
Right.
Oh.
Yeah, that's a pretty big statement when you go back and look at that graph where CLTI is compared to some of the things that are tremendously in the top of mind.
You're right. You'd think we would have a better understanding, or at least awareness of the dangers of it, but somehow it hasn't. It's just not that popular. So,
no, I look at that and it makes me think that, in one of your earlier slides, you talked about how I think it was only 21% of the population even knows about PAD. And I was wondering, well, maybe that's because Big Pharma hasn't gotten us $1 million or multi-million-dollar drug to advertise on the news every night. That, we get commercials for all of these different diseases that were never talked about before. That's just maybe some sarcasm there.
Well, no, it's true. And a little later, I'll talk about one medication that's on the market now that has been developed and has been shown to make a significant reduction in these events. But you're right, there's not a lot out there. But to talk a little bit about how peripheral arterial disease develops, this is something that I don't remember learning along my educational pathway, and yet I think it's really interesting. So I'm hoping other people feel the same. But it's why does PAD develop? It's not just like your arteries get clogged up, and then once they get too clogged up, you start having ulcers.
Right.
But there are four large groups that we talk about when how PAD develops. And the first is inflammation. Inflammation is very, very common for many of the disease states we see. Certainly with diabetes, it's made worse by smoking and certain other conditions that just have detrimental effects on health. But an inflamed artery is one of the precursors to all this happening in the first place. And the next is the inner lining of the arteries become diseased, and we call this the endothelium. So once you develop endothelial dysfunction, the process has a chance to worsen and to speed up to the next level. And one of the worst things we have to deal with are lipids. These cholesterol type and triglyceride chemicals in the blood that we talk about as being LDL or HDL. And it's a little bit more involved than just those, but it's extremely common, especially in the standard American diet, that we have high levels of unhealthy lipids within our system. And lipids are one of the processes that drive the development of atherosclerosis. And the fourth aspect is something that really doesn't get a whole lot of screen time, and that's the effect of thrombin in the body. Thrombin is part of the clotting system that we use. That's very, very important. So our blood clots, so we don't have excessive bleeding. And it's extremely important in the regulation of how our body works. But thrombogenesis, this formation of thrombin, is one of the key factors that leads to the severity of atherosclerosis. And again, it's something that has gotten much more research recently than in the past, where we have talked about these other three items a lot. But it's very, very important for the development and also for the treatment options that are available to us now. So first is inflammation, because basically, atherosclerotic heart disease is an inflammatory condition. Again, we talk about there's a number of inflammatory components to this that I won't really get into now, but we know that inflammation is extremely important to a number of the disease states that we tend to see nowadays. We also know that it's extremely popular in modern medicine as to one of these health-degrading concerns, that we're trying to take medications that might reduce inflammation in our bodies. We talk about it being bad, but inflammation ultimately is one of the processes that keeps us alive. It helps us fight infection. It helps us to heal wounds and such like this. But it also has the other side where it can drive some of these pathologies to a greater level. So trying to keep inflammation in a healthy balance is extremely important.
It all breaks down from acute inflammation to chronic inflammation.
That's an excellent point. You're right.
You got to have the acute to get healthy and your wounds to heal, but you can't have it become chronic, because that's the harbinger of disease.
Yeah, that's very, very well stated. You're right. But within the arteries, the inner lining is called the endothelium. There's tends to be three different levels of cells that line the arteries, and the intima is the endothelium. This very, very thick, only one or two cells thick, that line the arteries themselves. And it's extremely important because when they're healthy, your arteries are able to dilate and constrict, and they're able to allow certain types of healthy chemicals to come through it to get into the inside of the artery and such. And a certain development of hydration and fluidity within the blood is important for this. But over time, the endothelium becomes damaged. And this happens from smoking, inflammation will do it, too much glucose levels will damage it. But what happens is this protective lining that tries to let good things in and keep bad things out becomes damaged to the point that it can't act in a healthy manner. And when this happens, we find that things can get into the artery that are not so healthy, that we'll speak about in just a minute, but also the endothelium is extremely important for the formation of a chemical called nitric oxide, which you probably, Stephen, you've spoken about this before. You've looked into how important nitric oxide is for a number of different systems of the body. And when it's reduced, and the endothelium is one of the major parts of the body that forms this nitric oxide, for vascular health, if nitric oxide is not created enough, it can't function, the vessels can't function in a healthy manner.
Yeah, absolutely. John, the more I learn about nitric oxide, it may be one of the most important molecules to human health.
That's an excellent point. I know with your research in neuropathy and its effect, you've also pointed out how important it is for that problem also.
Yeah, well, I mean, it's unbelievable how, I think you're going to show a slide here about how your body, as you age, just makes less. There you go. Less each decade, you're producing less nitric oxide. So at age 40, you really everybody should be supplementing to, with something to increase their nitric oxide, in my opinion. And we've had a couple of great episodes on nitric oxide. But go ahead. I think this is fantastic.
No, and I would refer people back to those episodes that you've spoken about, because nitric oxide is something we hear about through the lay literature a lot. But it really hasn't entered into standard medical discussions of how important it is. And yet, specifically, when we talk about just the arteries, we see that every decade there's a significant reduction in the ability to form nitric oxide within these arteries. And that one factor drives the development of atherosclerosis in a way that we'll talk about a little bit. So these endothelial cells are important because they allow chemicals to come in and out of the artery, of the walls of the artery. And they also have a lot to do with the protective function. And so there are chemicals called free radicals that develop that are extremely dangerous to our health. And usually there are ways that these can be mitigated or reduced. But as the endothelium is damaged, we see a significant increase in these ROS, the oxidation, these reactive oxidative agents that cause these concerns that lead to chronic inflammation and these cytokines that are released, these inflammatory substances from the cells. And they also increase the ability for white blood cells to adhere to the vessel itself. And we'll talk about this in just a minute with one of the blood cells, the platelets. But the artery is just not able to react in a healthy manner. And so the endothelium, the longer you've lived, it will become more and more damaged. And if you smoke or if you have high glucose levels, all of these things can affect them, along with high blood pressure, which just physically damages the cells itself. So all these things kind of go together, but they add up when we're talking about the development of atherosclerosis.
Several years ago, I chose Alpinion as my ultrasound brand of choice after years of experience and research into ultrasound imaging. In fact, I have 2 of their machines. Alpinion has incredible precision and penetration built into their technology that, in my opinion, is simply the best value in all of the ultrasound imaging space. They have several price points to meet your needs, and I can tell you definitively that you'll end up having to pay double to achieve the equivalent imaging quality from other top brands. That doesn't even account for the unlimited software updates and remote tech support included with no monthly fees. Right now, to show their appreciation for the listeners of the Pod of Inquiry, they're offering an incredible discount. Their portable i7 retails for $21,000, but you can get it discounted at most medical meetings for $19,000. But my listeners will get it discounted to $15,900. This has never been offered anywhere for the new portable system with the engine of a console system. Use code SBPOI to take advantage of this incredible offer. You won't be disappointed with Alpinion. I sure haven't been.
We hope you all enjoyed today's show and got some truly empowering knowledge out of it. You can always follow up on anything we talked about in the show notes, found at our website, podofinquiry.com. If this incredible and educational conversation has tickled just a little bit of your cortex, please leave us a review and spread the message to your friends and colleagues. Let's keep spelunking.
This podcast is designed for informational purposes only and does not constitute any medical or surgical consulting advice or imply a development of any physician-patient relationship. The opinions of guests who are featured on the show are not necessarily the opinions of Dr. Barrett or the production team. This podcast is owned solely by Barrett Medical and Surgical Media, LLC. While the show is highly oriented for physicians and healthcare providers, anyone interested in the improvement of human performance and understanding will find us a welcome goblet to sip from, or guzzle. However, no representation or warranties are made in any way whatsoever on this podcast for any products, techniques, or other things discussed. Invited guests are not vetted by the Pod of Inquiry for their qualifications and may have a direct or indirect financial interest in what they present and discuss on the show. The Pod of Inquiry disclaims any responsibility from anything taken from the show, if used personally or professionally. It is a responsibility of the listener to perform their own due diligence prior to the implementation of any ideas, products, techniques, or anything talked about on the show.